Thank you, Dr. Pradeep. And thank you for the foundation to initiate this. And it's an excellent opportunity for me to present over here. Thanks for the opportunity as well. Thank you. Good afternoon from the Department of Intensive Care Medicine at Royal Care Hospital. The fever in ICU, which is not responding to antibiotics. Will you add antifungal without proof? So do we need the proof? So that is the question, and I would say probably yes. And the overview of the talk would include what the context would be, why and where we are in such a clinical situation, what are the evidences that we have got, and what are the guidelines that we can rely on, and what is the clinical relevance as well. So what exactly is the context? So if you look at globally, I think we have got enough papers to suggest a study among 23 ICUs among 9 European countries, giving us a data that the incidence of candidemia, where I'm choosing candidemia being the number one fungal infection in ICU, that the incidence seems to be around 7 episodes per 1,000 ICU admissions, and the crude mortality rate is huge at around 42%. What about across the world? You've got nearly 1,200 odd intensive care units participating across 76 countries, and the prevalence is pretty much the same, around 7 episodes per 1,000 ICU patients. And again, the crude mortality is huge. And what I wanted to impress upon is the length of ICU stay in patients with candidemia. It is nearly 33 days as against the gram-positive and gram-negative infections of 20 odd days. So quite an intense problem there. And what kind of ICUs do these patients are harbored in? Probably medical ICU is having a higher incidence when compared to surgical ICUs, and the incidence is quite high with mixed ICUs as well. And Candida albicans seems to be the most frequent isolate across the world. What about the Indian context? So there is quite a significant mortality occurring because of the candidemia, and the overall incidence within the Indian context is still the same. And what is interesting to note is you've got the median day of occurrence is much lesser. The median day is roughly 8 days. And even in patients with less severe physiological score, you've got the occurrence of candidemia, and the mortality is still the same. So what we are going to argue or suggest from my perspective is that we are not in a position to look at the risk and give a prophylaxis, which is a totally different group of patients that we're going to deal with. And within this context of ICU, the invasive fungal infection can range anything from 20 to 90% among septic patients having fever while on antibiotics. And if we were to rely on waiting for the diagnosis to come through, then probably we might be at loss. So what we are looking at is patients who have got symptoms, they are septic, and looking for other markers which can suggest probably we should go empirically to deal with them. There is a huge burden of having a negative blood culture among these patients. So what kind of negativity have we got here? So even in invasive candidiasis, I think we have got only less than 50% of them, there is a positivity. And if you're looking at intra-abdominal candidiasis, again, it will be less than 20% of the times that you're going to have a positivity. But most of the patients, we have got a good negative predictive value of the markers, which can suggest that we can withhold antifungal therapy even if you're going to start one. So there is a caveat there which we can rely upon. So majority of the time, there isn't a proof. That is a huge problem. So symptomatically, if the patient is going to have a risk, then we are going to have them on empirical therapy where there is symptoms and signs and the risk factors are there. So we need to individually look at patients whether there is a risk factor or not. Unfortunately, if you're going to delay things, there is going to be a huge mortality. So look at this paper, Gary et al., and subsequently Cortigini as well, highlighting that if there was a delay in starting fluconazole therapy, then by day 3, if it was delayed, then nearly 41% of them die. But if it was started earlier, then only 15% of them die. What they went on to say was there were independent predictors of mortality, which was increased time until fluconazole initiation was done, and of course the higher Apache score as well. So the suggestion was clinicians should take into account the clinical evaluation, risk factor assessment, the scores, the Candida scores, and other surrogate biomarkers to individualize and start the empirical therapy as soon as you could. And what are the risk factors do these patients harbor? So the odds ratio of all these risk factors have been highlighted here. And although the odds ratio is modest, it still is valuable in identifying these risk factors among the patients. So you've got further risk factors of renal replacement therapy, the mechanical ventilation per se, and I wanted to highlight the 2 factors, which are a patient having sepsis and the patient who are on broad spectrum antibiotics. They do carry the risk factor. And what does the Candida score tell us? So it has been validated previously, but it has been updated now with this particular paper with the new sepsis guideline, what has been come through as the sepsis 3 criteria. And still those parameters holds good, that sepsis is valued at 2 points, and somebody on total parental nutrition has 1 point, surgery as 1 point, and Candida colonization at 2 or more sterile, unsterile sites as 1 point. And that would still have a incidence going up quite significantly when the score is 3 or more. So how could we use the biomarkers to risk stratify patients? So there are quite a lot of suggestions, scoring systems that are in place, and the Candida scoring more than 3 is something reasonably validated. But if you have to look at what I wanted to emphasize is the negative predictive value of these parameters, where you should emphasize and individualize the care as to when you're going to de-escalate the care. So if you're going to start empirical therapy, I would rather rely on these markers for de-escalation rather than on the positive predictive value of them. So biomarker utilization based on beta-D-glucan, if you're going to rely on the numbers, then probably majority of them would say as 80 picograms. But if you're going to increase it further to 200 picograms, then probably the specificity goes up and you can very well use it for your de-escalation purposes very well. So what does the European Society of Intensive Care Medicine and the European Society of Clinical Microbiology and Infectious Diseases Task Force make recommendations on? They very well say that the risk prediction models, because of their simplicity, high negative predictive value, should be used for identifying high-risk patients, which is coming up as a strong recommendation. Let us look at the guidelines from IDSA, specifically tailored towards what is the role of empirical treatment for suspected invasive candidiasis in non-neutropenic patients in ICU. So it's pretty much explicit. Empirical antifungal therapy should be considered in critically ill patients with risk factors for invasive candidiasis, and the fever is not because of any other reason. And the clinical assessment of risk factors, the surrogate markers for invasive candidiasis, the culture data from non-sterile sites, all these things should be taken into account for starting empirical antifungal therapy, which enjoys a strong recommendation with a moderate quality of evidence. Again, empirical antifungal therapy should be started as soon as possible in patients if they are in septic shock. So it is pretty much explicit. If the patient deteriorates further for septic shock, you would go on to give empirical therapy. But we have got the context of a patient who is septic in ICU. So I would pretty much value the first point of IDSA that we should go for empirical therapy. And IDSA pretty much explicitly prefers the empirical therapy to be echinocandin, and fluconazole can be a surrogate or alternative. And also it goes on to mention about de-escalation as well when there is no clinical response by day 4 or 5, and do not have a subsequent evidence of invasive candidiasis, or have a negative non-culture based diagnostic assay with a high negative predictive value, then probably you could stop that empirical antifungal therapy that has been started. So there is a definitive endpoint to it as well, which has been very well defined. And how about the European Society task force on practical management of such patients? So what they had to say was, if the patient is in septic shock or multi-organ failure with more than one extradigestive site having colonized, then they do recommend as well. And they go on to explicitly come up with this flow chart in terms of a septic patient who is non-neutropenic, non-transplanted patient, having a specifically abdominal sepsis. Then if there is an absence of the abdominal sepsis, then goes on for a higher incidence of candidemia, where you would rather look at the Candida score and the colonization index and exclude other reasons for the fever, and rely on other markers where you can still go ahead with an empirical antifungal therapy, because the likelihood of having an invasive candidemia or candidial infection is high. So you would empirically start it and then re-evaluate by day 4 or 5, and probably have a antifungal stewardship strongly based on that fact. And there is this flow chart on the right, the blue mark, saying that better individualization of the immune status and risk stratification of the patient will prove worthy with the aid of diagnostic tests as well. What is the empirical trial? I'm sure my opponent is going to lever pretty much on this trial, wherein the 19 ICUs in France have taken this, and the study had 518 patients, and the intervention was with micafungin, and the primary outcome was no statistical difference in patients alive and free from fungal infections at 28 days. But I would like to highlight a few other areas, which is that the secondary observation was that the micafungin group had a significantly lower incidence of new proven invasive fungal infections. And the other point I wanted to emphasize upon is the fragility.
Please mute
index,
Mr. Raja.
Come up with is how fragile the trial is. So if you look at the fragility index of this particular trial per se, it enjoys a score of 3, but it may not be adequate. If you compare it with the counterparts of many other intensive care trials, the number is pretty slim, and the validity of the trial per se can be very fragile if you're going to go by that trial. What are the other factors that I wanted to highlight upon? There are some key differences in the baseline characteristics of this trial, which the intervention group had only higher BMI patients more so, chronic renal disease patients and diabetic patients, when compared to the control group, where the chronic respiratory disease was there and immunosuppressed patients and septic shock patients were there. So the homogenization of this group wasn't perfect. And the trial goes on to highlight that the survival was noted among patients with higher SOFA score, and in the particular group was the critically ill subgroup, and they could benefit from empirical therapy. Additionally, there was a low participation of patients where the risk is high, like the necrotizing pancreatitis patients or the postoperative gastrointestinal leakage patients. So many studies previously have shown that surgical patients do benefit from empirical therapy. And what are we afraid of? And my opponent might argue that increasing resistance among Candida species is a risk, higher cost of drugs, potential side effects. But we are not going to put our head into sand like the ostrich, but we have got this rescue that the antifungal stewardship, if it is properly practiced, that we are going to de-escalate if the risk factors are not there by day 5. What is the harm in starting the empirical therapy? So we have also got the notion of this early empirical antifungal therapy. So where does it come from? There are evidences emerging, like Brewer et al., going on to say the time lapsed from candidemia onset to echinocandin therapy initiation can very well be shortened. And we have seen this before, that if you're going to shorten this duration, then the mortality benefit will be there. And the next flow diagram of this study highlighting that if antifungal therapy is started empirically, and of which there are around 51 patients where it was done, and the empirical therapy in 39 patients, 9 of them had a proven invasive candidiasis. Do remember the first slide where the culture positivity is very slim in these patients, but of the 30 patients where it was not proven, the response was nearly 18 out of the 30 responded to empirical therapy. That's a huge number. That's a huge number. What do we know about the survival benefit? Well, survival rate can be up to 90%, ranging from 50 to 90. And there are 2 studies of the empirical antifungal therapy that was reviewed over the last decade in this Journal of Fungi in 2022 recently, that 2 studies from Singapore and 1 from China did find that early antifungal therapy is an independent protective factor that reduces hospital mortality. And the survival is also better, especially in this group of critically ill patients who are admitted to ICU. At least 3 out of the 12 studies reported significant association between survival rate and early antifungal therapy they empirically started. So I think the evidence is emerging, and this is from the last decade of data through this article that has come up. And then the study by Koloff et al. Delayed antifungal therapy, which is defined as no antifungal therapy within 24 hours of onset of septic shock, will result in higher hospital mortality. So it's pretty obvious that we need to act soon. And this kind of flow charts, which are available in many of the studies, do suggest that you need to individualize patients, take the help of Candida score, take the help of biological markers, risk stratify them, and then appropriately start the empirical therapy, and then de-escalate at the earliest option, which will be around 4 days and 5 days. So one more evidence to state that from the American Thoracic Society, that invasive candidiasis is common and rather morbid complications from the critically ill patients. The diagnosis is elusive and often delayed, and beta-D-glucone has been proposed as a rapid method for early diagnosis of candidiasis. That is all that we know of, but we cannot take it in isolation. So that is my point, that if you're going to risk stratify patients based on multiple parameters, then you could very well start and stop as needed. So delay in initiating therapy is what we are concerned about. And if you're going to cause undue delay, that will result in poorer outcomes. And what do you think of IDSA and all these guidelines that has come up with? There is an editorial suggesting that when the experts looked at all these evidences, the applicability of the IDSA guideline per se, which is very clear to the extent of 97%, still is not applicable on a clinical note. So that is something to be considered. So if I am an average physician who is at the bedside trying to look at up-to-date, this is what they have to say. The decision has to be individualized based on clinical assessment, surrogate markers, and culture data demonstrating Candida colonization at non-sterile sites. So individualization is the key. And if I were to sum up, we should not generalize the results of any one particular trial, and that particular trial probably has a non-homogeneous group, and individualized care is the way forward. And early empirical therapy will save lives, and de-escalation with appropriate antifungal stewardship principles will hold our practice very well. And I leave with a clinical scenario, which we have got a diabetic patient, non-oliguric CKD patient with a marginally high creatinine, admitted for fever for 3 days, started on antibiotics, spikes in temperature persisting. Day 2, mild oliguria, shifted to ICU, and day 4, mild hypotension with fluid resuscitation, central venous catheter is in place, fever is persisting, there is no foci which has been identified in cultures. And day 5 gives you this data. Would you rather consider risk stratifying this patient or not, is my question. I may not be right always, but I am never wrong. With this, I leave it with a good luck to my opponent. Thank you.